Welcome. I'm Kevin Lobdell, Professor and System Director of Cardiovascular Quality Education and Research at Atrium Health and the Sanger Heart and Vascular Institute in Charlotte, North Carolina. We're pleased to have you join us with this ERAS Cardiac 2021. Today I'll be talking about engagement and enhanced recovery after cardiac surgery. My disclosures include independent quality consulting for Medtronic as well as Data Safety Monitoring Board. I work with the Impact Steering Committee for Abiomed, and I'm the recipient of the Perfect Care Grant with the Duke Endowment. Let's touch briefly on the eras of patient engagement. The paternalistic era is sort of the classic gray-haired white male surgeon that told their patients what they were going to have for a procedure with very little dialogue. It was mostly a directive. As we evolved, we entered what I would call the analog era, where we provided patients with educational materials, occasionally engaging them via brochures. But we're clearly in a digital age, and it's a great opportunity to truly engage our patients and not just meet at the time and place, but make emotional connections that help with compliance of the care, which is vital to the enhanced recovery after surgery efforts. Let's touch briefly on the digital age and exponential technology. We live in a networked world that's been transformed by computing and the internet. Peter Diamandis and Stephen Kotler, in their book, The Future is Faster Than You Think, describe the 6 Ds of exponential technologies: digital information tools, deceptive increase in scope and utilization, disruption, demonetization, dematerialization, as well as democratization of information or data. Let's also think about the devices and data that we all have and our patients use. 80% of patients have smartphones, and about 90% have some type of mobile phone. 17 to 29% of patients check their smart device 50 or more times a day, while the average person uses their phone approximately 2.5 hours per day. Wearables, meanwhile, are used in about 5 to 11% of the world's adult population. So patients and their technology, let's think about that intersection. Our average patient's over 60 years of age, and we must address the technical challenges with setup and use due to impaired mobility, vision, memory, hearing, social isolation, loneliness, and depression. A valuable aspect of this social interaction with the healthcare system that technology solutions will supplant is a part of what we encounter on a daily basis in this new era. The process of engaging patients via remote monitoring is important and involves building rapport, sharing of information, and providing guidance. So the goals of the technology and the transformation of healthcare. Briefly, I'll discuss the James Lind Alliance priority setting partnership that look to identify the highest priorities. They talked with 629 cardiac surgery patients, their caregivers, and healthcare professionals, and came up with some common themes. The most important that bubbled up were basic information, which included improving outcomes in patients with comorbidities, and things like minimally invasive versus classic, more invasive open heart surgery. Also, quality of life, so things like frailty as it associates with heart surgery, and the value of prehabilitation. And finally, risk. Things like risk mitigation and the management of complications that take place after surgery. So we really live in what we'll call the ERAS era, where it's incumbent upon us to engage our patients, to educate them, to monitor compliance, to foster institutional learning, as well as continuous improvement. With that, I'm going to share a couple of technology platforms that you'll find interesting. So first is Vox Telehealth. They come from a behavioral health background, and they have a keen interest in things like activation, utilization, survey response. It's important to know here that it's not enough that the patient just opens a welcome email, but to actually figure out who's utilizing the program and the components of their platform and even be able to drill down and figure out where there's compliance and engagement and where there's opportunities to improve. As you can see from some of the data they've collected, they're, with this focus and background in behavioral health, done a great job with patient satisfaction, improved experience, improving outcomes, but also very importantly, consistent with the quadruple aim that we're all trying to do, making work better for our clinicians, where you see that 78% of the clinical staff was more satisfied when engaging patients through this medium. And then finally, patient enthusiasm, where 95% recommended the platform. Bay State Health, Dan Engelman, Tom Schwann, who you'll hear from in ERAS Cardiac 2021, also have a rich experience using the Seamless MD platform for their enhanced recovery efforts. Through this platform, they have the ability to message with patients, have patients complete their tasks, be educated, also track their progress. An important facet of this has been opioid use, and you see, for instance, what the patient sees, but also the clinical team and their ability to look at these trends with populations over time. Their experience has been terrific. They've markedly improved readmissions, observation stay, ED visits, length of stay, and very importantly, the discharge to the skilled nursing facility, which all those know that have done work in bundled care or at-risk sort of contracts. It's a very expensive portion of the care. And remember that we addressed these platforms, this technology, to engage our patients in our original 2019 JAMA surgery publication, and gave these platforms and these efforts to engage patients a Class 2A recommendation. Onto our experience in the Carolinas, Perfect Care, which I alluded to earlier. We acknowledge that we work in this network, decentralized world with experts that we'd like to engage our patients through all phases of care. We've mapped out that work with the help of Carium, our partner in this work, and we've mapped out the details of their care through 90 days, and also include a patient-reported outcome survey at 1 year. With our basic digital health kit and a Fitbit fitness tracker, we monitor heart rate, steps, and sleep. We also give them a scale, and we've now migrated to where we're giving them a sphygmomanometer or blood pressure cuff to monitor and manage blood pressure. We include audio-visual remote monitoring for real-time synchronous visits. And this is a great look at the patient's app interface, where they're able to see their health feed, surveys, appointments, things like their blood pressure, when their next appointment may be, and also give us feedback on their care. These are screenshots or the graphical user interface from the web browser that the clinicians use. And as you'll see in the bottom right, specifically a patient, and then top left is to depict what we'd see in the way of trends in the populations. And just to dwell for a moment on the details of what we're doing, we're aggregating STS clinical data, financial data, the audio-visual remote monitoring information, remote monitoring in the way of the biometrics that I mentioned, patient-reported outcome measures, and we're working now to include clinician-reported outcomes, so we have an assessment of team and we can mitigate, for instance, the risk of burnout. So, summary and conclusions about engagement in these digital platforms. We work in a networked world with disruptive exponential technologies. These technologies can enhance perioperative recovery, and it's certainly feasible. There are many of us out here doing it. And finally, the technology supports patient engagement, institutional learning, and may improve quality, safety, and value. With that, I'll end, and I thank you very much.
Okay, thank you. I've just been informed we are running concurrent sessions, and we broadcast, you may have heard the talk from the other session in the room you're in, but we're going to switch the rooms back. And if you heard the wrong talk, don't worry, because it's all ERAS, it's all valuable. And we'll cover a lot of the topics in the panel discussion. So if you just give us a moment, we're going to switch the rooms back to the appropriate titles. Welcome back. We are back. This is the session on how to get your patients engaged. Dr. Lobdell just gave us a great pre-recorded talk. If you happened not to see it because there was some technical mix-up, then you probably got a great talk about rigid sternal fixation. And if you want to see Dr. Lobdell's talk, it will all the talks are on demand, and they'll be in our video library. And it was a great talk, Kevin. Thank you.
Thank you.
And you're obviously very far along on this journey compared to maybe any of us. But what's your advice to someone in a program where they're naive to all this technology, but they want to have a digital solution to engage with their patients? Where should they start?
That's a good question. I think what I would do is probably work with the organization that you're in and the people in information services, along with talk to some of the vendors in the area. We live in that network decentralized world, and you could start with Google if you didn't have those contacts, but certainly some of the companies like we mentioned, Vox Telehealth, Seamless MD, Carium, there are a number of solutions out there, and the people are very good now, sophisticated, particularly in the COVID era, can give you real live demo, interactive demo, so what it looks like for a patient, what it looks like for the caregiver. But back to your point, many of the clinicians are probably not familiar, and getting other knowledgeable people about what that journey will be like is important. One thing I might say that's of value, having been on the journey, if your institution already has a solution, even if it's in a different specialty, that can often be easier to modify than to start something from the beginning.
That's a great point. And in fact, at our institution, we went to the orthopedic surgeons who had been doing this already, and we learned from them and got a cardiac surgery solution that we actually worked with the company to help design. And I believe Cheryl, you've done a lot of designing of your digital solution.
We have, and we actually had the opposite situation where we had started our digital platform for patients, and then the hospital had a system they brought in, and we really had done so much work to customize our platform, whereas it was a more generic platform that was brought in. So we negotiated to be able to keep ours in addition to the more generic platform. It becomes very important to keep your information up to date, and when you've put so much into it, it starts to build your library that you're giving your patients. They're out there looking on the web for information, and you really want to have a source of truth to reflect what you want them to know for your program, and we found that very valuable to keep intact.
And my question for you, and also for Gina, I think, who probably have the most experience with actually on the ground interacting with the patients and this technology, I'm wondering, what are some of the pitfalls that you could share with the audience? Things to avoid, challenges, things that are difficult?
Great question. Not everything's a home run, and we learned that early on. There's no one size fits all when it comes to patient engagement. And I'll give you an example actually of something that did not work well, which was trying to get people to go to prehab in an outpatient setting. And very few were willing to make the journey to another appointment, pay a copay, and then when COVID became an issue and the gym was closed, we had to regroup and figure out what we could do for our patients. So we're in the process of building a prehab program that will be virtual. We hope will be more successful. We're using the same team to help us build this that helped us with the outpatient side. So not everything is going to be successful, and not every patient can use digital. So we do have to keep paper forms and maybe things that are online that are much easier for them to be able to access. And then there's always language barriers that pose a challenge because so much of our information is in one or two languages.
Great. Gina, what's been some of your experience?
I agree with Cheryl. We have to adapt to the patient's needs. A home run would be that we developed this beautiful platform and it was perfect and it worked for everyone and we were done. That would be a home run. We're never going to have quite that. We have to just realize that we have to develop things in different opportunities because patients and families are learning differently. So I completely agree with Cheryl. The digital and patient-facing world, beautiful. I love it. 5 years ago, I think we've come leaps and bounds from, if you would have told me 5 years ago, every 75-year-old person was going to be on their phone, I would have said, I don't think so. But now I think we have an opportunity that a lot of them are. And given the virtual world, this gives us another avenue to reach them and keep in touch with them without having to come in contact with them. So paper, digital, virtual, there's so many opportunities, but we have to kind of utilize them all.
That's great. And before we go on, let me just take a moment to say to the audience, if you go to slido.com, and for this session, you can enter in questions. This panel discussion is going to go till about 2:20. And if you put in the code cardiac B, then you can enter questions for this session. And Nick, while people are doing that, can you tell us a little bit about what's going on in the UK with regards to digital facing solutions?
Yeah, it's interesting hearing the discussion, and Kevin identified sort of very technological solutions. I think I'm caught between two worlds. It's a really interesting place to be. So I'd say it's about communication and it's about partnership primarily. And the old way of doing that is really about building trust. And without technological platforms, and that's establishing relationships. And I think with our increasing use of technology, we need to make sure we don't lose that. And remember, it's about trust, it's about communication, relationships, and the enhanced way of delivering information we have. So in the UK, we have something called the National Cardiac Benchmarking Collaborative, and we get all our cardiac centres together within the National Health system, which all our cardiac centres work within the public system. So we kind of meet up, and we've had a few focus sessions on cardiac ERAS. And really, it's about our specialist cardiac nurses making contact with our patients early. You know, using the old analog forms, which is still kind of where we are in the UK. We've not taken up technology as much. But it's using the old tried and trusted methods, the nurses having early contact with patients, making it a partnership. You referred to the old paternalistic methods of you tell the patient what was going to happen to them, you tell them what the chances are they were going to die. When we talk about enhanced recovery, we're telling them it's not about whether they're going to survive or die, it's about the recovery they're going to make, I think. And that's still the key message. Even if we're doing that through technology, that's the key message. Now, as I'm designing things at the Cleveland Clinic London, which is we're still about 10 months away from opening our hospital, but we're opening our technology platforms, and we use Epic, we're using MyChart, and there's a lot of information we can deliver to the patient. But one of the things that I've tried to do so far is to put ERAS right through the organization, if you like. So we're trying to put ERAS in every single type of surgery we're doing, and we're trying to tell the patients about it, and we're trying to get the patients involved in it early so they know and they understand what it means. Am I still there?
We're going to go to 225.
Okay, gotcha.
So you're good. Thanks. I'll fix it.
That's great.
So we're between two worlds, I think, in the UK.
Well, I think that's an excellent point, Nick. And we do have to remember that as we use digital solutions, that we stay human and remember that medicine is about the human touch and supporting other humans through their illness. That's a great point. And that does also kind of speak to what Cheryl and Gina were saying about different families learning differently. What has everyone found to be about the level of engagement they can get with digital solutions? What do you know, what % of your patients are actually utilizing the programs that you're setting up?
I guess I will take this one. I would say we have about maybe 65% to 70% of our patients that will sign up, and then it drops down on how many activate the platform, and then how many stay consistent and use the platform. And somebody put a question into Slido, which is a great question. Patients are excited about this. They maybe answer a few surveys, and then the engagement drops off, and what can you do about that? And my answer is, you're only able to get people as engaged as they want to be. Just like we've always had some patients that want all the information and read and research, it's the same thing with the digital education. And my answer is, make it as easy and friendly for them to use. Make sure that your patients know that they can reach out to you if they're having trouble opening the platform. I think that is, sometimes they've used it a couple times before they came to the hospital, and then they forgot how to get in, or their password isn't working, and I let them know, just call us and I'll be glad to talk you through it. And I am concerned that sometimes that is where it seems like they're not using it, but they may be having problems with it. So making sure they know what to do, and making sure there's alternatives. If the online platform isn't maybe the best for them, having handouts, you still need to have those for those patients, and making sure that they have a way to communicate with you 24 hours a day. We tell them they can call our team for advice or for issues. And once they know that that is an option, they sometimes will take you up on that. So it's just not, you can't force them, I guess is the point.
Well, let's pick up on that for a second, Kevin. You mentioned in your talk that at least one digital platform has shown decreased readmission rates. But say you're speaking to someone who says, well, we speak to our patients in person, we don't need this digital solution. What's the advantage of it? I mean, what are you seeing? What's been proven?
Great question. I don't know that we could, any of us, make the argument that something's proven beyond a doubt, because getting things like this to scale in multiple institutions is a challenge. Mm-hmm. And there's always going to be questions about a study. But let's try to pull together what we've heard, and it really capitalizes, I think, on what Nick has emphasized. This starts out as a human relationship based on trust, and you need the Cheryls, the Gina, and in our world, the Shannon Crotwells of the world, to get these people engaged, build that trust. And then comes the technology platform. And here's the best analogy that I could use. If historically the care that we've delivered looks like snapshots, with this technology we can now create a movie for the patient's perioperative care. And there are many, many more touch points when you look at what people travel. And I know we were even discussing this informally before this session. Patients, it's a real burden to come and sit in an office and to leave, to park, all those other components. Now we can do it in the comfort of their home, almost on demand. Now, there's a lot of details on this journey, right? Picking the right technology solution, absolutely getting the right team to partner with, having the right people in your organization doing this work, right? going on that journey. And then every time there's an obstacle, finding a good solution on workflow and interoperability, that sort of thing. But again, let me emphasize, I think that it's an and solution as opposed to an either or. And what you really go from is episodic, or like a photograph of their care, to a movie. So it's a much more integrated view of their care in their own setting where they spend most of their time.
That's a great point. I do think we're hearing an increasing chorus of patients that are asking for care to be delivered to them. And there certainly is some innovation in that area.
And Ron, I'd just like to say something in regards to that.
Please do.
The premise of what we always want to do is have that relationship. That's never going to be changed. I totally agree with Dr. Lobdell. That is the foundation of how we are going to get things done and have better outcomes. But the reality is we have gaps. We have resource issues. We have gaps that we aren't allowed or able to devote more time to our patients sometimes. And if this is just an addendum, if this is just another layer, it's not in place of. Never ever. I agree with the whole panel. This is not in place of. It's a layer to help us give our patients more attention, build more relationships on the backside when they're at home in their own home. So I agree with Dr. Lobdell. It's not an either or. It's just another avenue we can utilize to help our patients.
That's a great point. I like that. I like both, and I like your movie analogy a lot. When I was thinking about this session, it seemed to me, and we've been implementing a digital solution for about a year, but we still are ramping it up. It's still not fully functional. A lot of that time has been spent developing the content. But it seems to me that one of the advantages would be to develop or to track real patient-reported outcomes and longer term than we traditionally do in this country through the STS database. Is anyone doing that, or have you found that to be successful?
I'm going to give you an example of probably our most powerful one. Was when we first started using our digital platform, patients were asked surveys while they were in the hospital, and one of the surveys was related to did you ambulate 4 times today, or how many times did you ambulate? And our patients were putting in, these are the patient reported outcome, I didn't walk today because I didn't have enough opportunities from staff to help me. That was pretty powerful. It wasn't any of our words as providers, it was the words of the patients, and it wasn't just one patient, it was multiple. And our teams really took that seriously, and we've hired walking orderlies to support our intensive care unit, and that was because of the direct comments from our patients. So I would say that's pretty powerful.
That is fantastic.
And to amplify that, we decided to pick a validated survey, so we use the Promise 10, and we do that intermittently all the way out to a year. So yes, there's longitudinal follow-up. And our standard clinical follow-up with the audio-visual remote visits are out to 90 days. And the logic behind that is much like you allude to. It's not just a single post-op visit, or for that matter, a month of tracking them. A lot goes on in that first 90 days, and we know that the future, if not already in some places in the US, you're going to be at risk for bundled care for 90 days, so we tried to design around that.
Has your place been following for 90 days?
We follow for 30 days from the time of discharge.
30 days. Gina, what about you guys?
We are actually in the midst of still building, so we haven't even gotten to the place where Dr. Lobdell and Cheryl have, so we're still building.
That's great. Nick, what's your experience been?
Patient-reported outcomes. We've been doing it for certain things, but we haven't been doing it for ERAS yet. We're not quite onto the ERAS track, but we've been developing national patient-reported outcomes in the UK for a little while, and we've been trying to orientate it so payments may follow some elements of patient-reported outcomes. It's not a perfect system yet, but I think it's a reasonable attempt. I think one of the other things I just wanted to say about engagement, And there's actually a really nice study from Greg Nelson's unit in Alberta with colorectal, which I think is really interesting, where they did some really good qualitative research with patients, asking what drove their engagement. And one of the key things they found was peer-led patient programs. So getting patients who've been through something to act as patient champions, because maybe even if a patient's maybe not always comfortable with their nurses and doctors, they often respond to other patients. And I think the key thing in a way is personalization. So some patients may want their doctor, some patients may want their nurse, other patients may want to talk to other patients who've had the same thing. And I think if patients are able to access a forum where they can talk to other patients who'll be a champion for enhanced recovery, I think that's a great way to go. It's a great resource to provide.
That's a great point. We have a question coming in from the audience, which anyone can take. It says, basically, have any of you found increased engagement if family members are involved on behalf of the patients? And has that been helpful?
We always offer our platform up to family members, caregivers. We offer it to an unlimited amount. So sometimes I'm registering 3 and 4 people on one subscription, you might say. And definitely family members are key. And we've had less opportunities for visitors in our hospital due to COVID. So this has allowed us to be able to have the pertinent information family members will need to help care for their loved ones when they go home, so they can access videos and self-care tips that the patient's going to be given ahead of time. So, you know, it definitely has been helpful during this period to have that opportunity to put that information in the family members' hands as well.
And is yours a two-way interaction? So do you send them questions that they need to send answers, like surveys they send answers back to, or
the patients
weight or glucose or anything?
The patients are sent survey questions, and they send us in answers, and they can free text us in information. And we let them know that this is a self-care tool. So after their responses are put in, they're given almost a report card where it says, good to go, you're on track with your recovery. Or it might say, you have these issues that we would like you to call into our practice to help address with you. Or it might say, you need to call 911. So based on their information, they're guided. We see their comments that they write in, but it's a one-way communication with them being prompted to call us. The platform is not monitored 24 hours a day, 7 days a week, but we check in on it regularly and address any of the concerns that are in there that need to be addressed.
So if they hit a certain threshold, it'll automatically send them back a message saying either call the office or come into the emergency room or something.
Yes.
If it's something concerning.
And we have our office, our team, our practice team has been amazing support of the platform. So they are taking calls, and it goes to the service and goes to our inpatient APs. Also amazing support of our program, and they take these calls 24 hours a day. 2 in the morning, they get calls.
And have we found this, have people found this to be more helpful pre-operatively educating the patients, or is it more helpful post-operatively kind of keeping a tab on them at home?
Well, I think to answer that from our perspective, most of our experience is with the post-operative, so we will engage people pre-operatively, but I think unlike, say, other systems, maybe Nick in the UK or Rakesh and some of the others in Canada where they'll have waiting lists, that's pretty uncommon for us. So we'll definitely have a mix of people that would be seen in the office and prepared for elective surgery, and then those that are brought to the hospital urgently done. So the majority of that focus has been in the post-operative period.
Is that the same for you?
No, we have a robust amount of information for the pre-op preparation, And as well as it has a library, so there's some patients that devour that library and read their discharge instructions and watch their discharge instruction video even before they come in. But it gives them information to help them prepare, know which medications are held before surgery, know about bathing and pre-op and all the protocols we want them to follow.
Great. And has anyone used that? Gina, maybe you could pick this up. Has anyone have a system that actually, does it stop when they enter the hospital and start up again when they leave, or does it actually follow them all the way through?
I can't answer that. Cheryl or Dr. Cheryl probably be able to answer that better than I, but I was just going to address the comment you made about utilization of this tool. Mm-hmm. Would it be better, are we seeing it more in the discharge phase, in the intro or the pre? And when you talk about all the work we've been trying to do with prehab and optimization of our patients, this is where I have, been looking at this. Could we use a platform to reach our patients and optimize them before surgery in the prehab phase? And so I think not there yet. COVID kind of halted all work that we were looking at that. But how awesome if we could get this into the hands of our patients a month or two or even a couple weeks prior to their surgery to optimize them and have that communication. And I see huge benefits in that once we get there. I'm not even near there, still working on it. But I think the question about continuization of that app, probably Cheryl could answer better.
And just before you address that, just for the audience to understand, Gina McConnell is the ERAS coordinator at Wake Med. They had the first full ERAS cardiac program in the U.S. and published excellent results. And I think it's just a tribute to ERAS in general and just to the people involved that you hear Gina saying, this is something we're working on, this is something we're developing, and you see even one of the most leading edge mature ERAS cardiac programs in the country still trying to develop more and learn more. And that's a lot of what we're all trying to do here. So that's great.
Absolutely.
We all have our areas that we have excelled at and worked hard at, and that we're learning from each other the pitfalls as we pull these things together. I think that's the beauty of this journey that we're all on with ERAS. And somebody wrote in a question that asks if it's fair to say that the virtual technologies are still staffed by humans. And I can only speak to the one we're using. And as I said, it's not staffed 24/7, but it is certainly monitored and would not run itself without having some people behind it. You couldn't just put this out there and have people writing in things and not have it attended to. So yes, it does take having some staff and resources dedicated to our platform. One platform might not work for another place if that is the case, and there's options, but you have to really talk with the providers and whoever's helping you put that together.
I think that's a very important question, and I'm not sure if this is what they were getting at, but for us, it was very important to identify, and I'm wondering if it's the same for you guys, identify one point person who really is driving the registration, making sure that the content is getting pushed out correctly, and kind of getting feedback from patients asking, is this working for you? Is your family signed up? Or is this helpful? Have you guys found that you need that one point person?
At this point in my career, decades, I've learned you have to have somebody that owns efforts of this nature. Mm-hmm. If they don't, if it's a system effort, it has a way of taking longer than you ever wanted and being much more circuitous. So I think that the Cheryls, the Ginas, the Shannon, as I mentioned in our place, that champion that, they own that, they spread it to the teammates, but they still own the program is vital.
One of the things I would love to see is for us to all be able to share a little bit more of, so we're all trying to work on prehab, and I'm working on it as well, and I would love to, see it be that we all share our efforts more and more. So it's great that we all kind of can collaborate and let each other know, so we're not all doing the same thing.
That's a great point. And the companies, to the vendors, to their credit, so far, everyone that I've spoken to has said, yeah, we're working with this, we're working with Bay State, we're working with Houston Methodist, we're working with Atrium, and working with Montreal Heart, and all that content will be available to you. So it has been a kind of sharing platform, it seems.
That's exactly,
so far.
we started with the platform that another institution had, and then that's how we customized to our platform. And it gets bigger, more robust. Every year we add to it, and it becomes more and more of a reflection of what we want our patients to know.
Yeah, to amplify that, and we talked about this sort of informally on the way over from the hotel today. There's sort of two ends of the spectrum in this technology world. The one is the patient-facing, clinician, utilized platforms that we talked about. But the other is setting up the data as a platform where you can take the various sources of data, aggregate them, use them to analyze, make sense of things. And how does that all fit together? Well, much like we're talking about, creating collaborative and improvement networks independent of geographic location becomes the real advantage, because you're getting people with expertise and energy to come together. And so we'll have ERAS elements, we'll have technology platforms, we'll have the ability to aggregate data, make sense of it, and then we can truly learn together. That's all on our strategic roadmap, right? And so I think we're right at the threshold of being able to do that.
So Nick, maybe when you're done building a Cleveland Clinic in London, you can build us an AI neural network for patient-reported outcomes worldwide.
Yeah, for sure. Just order up what you want, and I'll put it to our IT team. Yeah, I think. I mean, one thing we've shown. I mean, there was a question about older patients and younger relatives. I think we've really converted a lot of older patients to digital technologies, particularly with this pandemic, and there's great opportunities, I think, to engage more digitally with older patients.
Yeah.
Great.
I think they kick me out.
Are we wrapping up now? Okay, so it's time for us to wrap up. Thank you everyone for sticking with us through our brief technical difficulties. Please remember to visit our sponsors in the exhibit hall, and you can get your Amazon gift card. And thanks again for tuning in. Thank you to the panelists for tuning in.
Thank you.
Also
Thanks. We hope to be in the same room next time.
Okay.
Yes, we do.
Thank you for this opportunity.
Bye, everyone.
Bye.
Thanks.